So this is Wahid Kazai. Today we are presenting EACTA Thoracic Webinar, Recent Advances in Lung Isolation Techniques. We will acquaint you with common methods which are used successfully in our practice in large thoracic centers. We will present. We will also update you on new developments in this area. By the end of the webinar, you'll be able to define indications and relative contraindications on using double lumen tubes or bronchial blockers. We will show you how to integrate video-assisted intubation and video-assisted lung isolation techniques in your practice. We will show you how to make appropriate decisions regarding lung isolation and one lung ventilation with anticipated or unanticipated difficult airway, and we'll discuss airway management in very special case of lung transplantation. As we're talking about airway management, we'll not only have a theoretical discussion, we'll provide you with practical advice on how you can integrate this in your daily practice. So I think we have to go on now, and we have one more talk, and this is going to be given by Dr. Nandor MArczin from Imperial College London, and he's going to talk about lessons from lung transplantation. So, Nandi.
Thank you, Wahid. I realize that we are getting late into the evening and we have overrun slightly. So this is just a short presentation to highlight how the concept of today's webinar could be adapted to a very specialized aspect of thoracic anesthesia, as you mentioned, namely lung transplantation, which presents with some unique aspects of airway management. And also after that, I will be bringing in some international society activities for our topic as the next step. So lung transplantation is obviously the last resort for many patients, and usually the only therapeutic possibility for patients with end-stage lung diseases. And it may be restricted to one transplant only, called a single lung transplantation, whereby one of the diseased lung is removed and replaced by a donor allograft. The procedure then will require full lung isolation, critical one lung ventilation with limited functional capacity, followed by pulmonectomy, implantation, and reperfusion of the donor allograft. However, many patients require bilateral transplantation, whereby a single lung transplantation completed on one side is followed by isolation of the second nating lung, pulmonectomy, and implantation of the second allograft. And the next slide will demonstrate that the number of bilateral lung transplantations are taking over the single lung transplantation according to the International Society of Heart and Lung Transplantation, and mainly because the overall survivals in these lung transplantations are better than the single lung transplantation. And today what we will do, we will consider three major aspects: the methods of the lung isolations, some of the intraoperative issues, and the airway exchange at the end of the procedure. And I will utilize this slide to make a case that we usually use the left-sided double lumen tube as the routine airway management device for lung transplantation. And this cartoon shows that the recommended practice of the transplant surgeons regarding the preferred level, bronchial level of the airway anastomosis. As you can see, these are advised as close to the bronchial bifurcation as possible in order to avoid some areas that are prone for airway ischemia. The consequences of this are on the right-hand side, that the bronchial anastomosis is very proximal to the main carina, leaving only one or two bronchial rings for the anastomosis and precluding any cuffed device on the right side. However, on the left side, the anastomosis leaves most of the left main bronchus intact and available for double lumen positioning on the left side. Accordingly, in left-sided single lung transplantation, the left double lumen tube is the preferred choice. For left-sided single lung transplantation, however, a right-sided device could be considered. However, here we have the problem of the right upper lobe ventilation, which is essential due to the severity of the reduced lung function. Hence, in this scenario, left-sided double lumen tube is still possible and perhaps one of the safer options. Based on these considerations, again, for bilateral sequential lung transplantation, the left double lumen tube is the preferred choice for lung isolations. However, in very small patients, for example, with cystic fibrosis, there should be a consideration for a larger airway, and in this scenario, a single lumen tube and a blocker has been considered and suggested. In this paper, early paper from the Cleveland Clinic, the authors would start with a right lung transplantation, and in this case, lung isolation would be provided by the single lumen tube advanced to the left main bronchus, allowing dissection, pneumonectomy, and implantation of the right lung. At this stage, the tube would be pulled back to the distal trachea and the blocker placed at the left main bronchus, allowing the dissection, one lung ventilation, and transplantation of the left lung. There are particular issues with difficult airway management in lung transplantation, and many of the concepts that Wahid has described would be applied. However, because of the reasons I explained above, there should be some more emphasis on achieving a double lumen tube placement. However, this is usually in the middle of the night with little help available. Therefore, identification of a potentially difficult airway is paramount. Also, for the same reasons, seeing these patients, the potential lung transplantation recipients, daytime would be important, and there are implications of a prolonged difficult intubation procedure for the entire success of lung transplantation, as this would potentially add to the ischemia time, and therefore careful consideration for coordinating timing and the preparation for a potential difficult intubation would be. The intraoperative issues I would mention the particulars of the one lung ventilation, as these patients have end-stage lung disease with very limited physiological reserve, very little room for errors, and the consequences of a failed one lung ventilation would be quite important, as most likely would require either ECMO or cardiopulmonary bypass, which then has a major impact on postoperative allograft function, primary graft dysfunction, and survival. Also, the surgical manipulations are very, very extensive, and therefore movement of the double lumen tubes or the blockers is paramount and is always a possibility. This would further compromise one lung ventilation. And bronchoscopy has to be used very, very frequently in addition to the initial procedures and placement of the device, as we have to check the quality of the bronchial anastomosis, as a delay in this would make rectification very, very difficult later. There are also multiple secretions and blood that bronchial toilets needs to be frequent, and therefore frequent bronchoscopy is required. However, these patients are immunosuppressed, and hence sterility is of paramount involvement. I use a lot of sterile gloves during the procedure. At the end, some patients can be extubated on the table. However, this is limited and not used widely. As the procedures are very prolonged, up to 6 to 10 hours, there is always a potential for even a normal airway to become difficult, and certainly a more difficult airway to become very difficult. Therefore, at the end, when we are preparing for exchange, a good laryngoscopy is essential. Use the video-assisted devices are important, and we may have the opportunity for the exchange catheter, as we heard in the previous talks. However, here we have the difficulty of the anastomosis, or preferentially or potentially on both sides. Therefore, the exchange catheter use must be very, very careful in order to avoid any injury for the bronchial anastomosis. Indeed, a few weeks ago, we encountered this patient who intraoperatively developed a major facial edema due to drainage problem and superior vena cava narrowing. And indeed, we suspected that the airway exchange would be difficult, and the laryngoscopy revealed massive mucosal edema, and we had to opt to leave the double lumen tumor in place. So moving on after this summary of the main principles for lung transplantation, I would like to highlight two international activities, society-backed up activities for our topic on airway management. And the first brings me to lung transplantation, and indeed there is an international consensus recommendation for anesthetic and intensive care management of lung transplantation. This is a multi-society effort involving 7 major societies, and the consensus and with the recommendations is currently under review. And indeed, the intraoperative management contains a variety of recommendations by 70 international experts and up to 50 leading institutions regarding airway management in lung transplantation. And the next activity brings us home to the thoracic subcommittee, which also set out to conduct a consensus project named the TOSCA, highlighting thoracic anesthesia consensus agreement. This consensus is aimed at reviewing the current practice and evidence in the major field of thoracic anesthesia and to arrive at a consensus. Obviously, airway management is a major part of the domains of this process, and this working group will be led by our friend Manuel Granul from Valencia, and all the current today's speakers will contribute to the deliverables. The major outcome will be a good clinical practice guide for routine output, but also we will be discussing educational and training aspects for competencies and to prioritize scientific plans for our near future activities. And this indeed brings me to my last slide about research priorities. And I do not want to preempt the TOSCA procedure. Hence, I refer to the meta-analysis by the Edinburgh group, which was referred to in many of the previous presentations. And obviously, they concluded that the available randomized controlled trials have some suggestion for the benefits of bronchial blockers, and the double lumen tubes can be placed quicker and more reliably. However, they obviously highlighted major limitations of these randomized controlled trials and concluded that more studies with larger populations and perhaps focusing on relevant clinical adverse events such as overall pulmonary complications when we compare these airway devices. And with these thoughts, I thank you for your attention.
Nandi, thank you very much for your talk. And there are no questions from the audience, but maybe there are some questions from one of us. And I'd like to comment your last slide, if I may. The problem is that until now, we have studied in these RCTs, the studies which are there. There's things you can study very easily. But when we look at the surveys, how many people use double lumen tubes versus bronchial blockers, there's a preference everywhere, and there's also preference. For example, I also have this preference, although I can work with bronchial blockers. It's not a problem of expertise. And when you ask me, why do you do it, then there's so many things I would say. I would say it's much easier to, deflate or reinflate the lung. It's much more easier to put only a little oxygen in. It's much more easier to go there and take out the secretions which sometimes impede air from deflating. And there's so many things, and that's very difficult to put all these things into one study. So what we have studied until now are the simple things, which because there's light under the lantern, you look for the key there and not where you lost it. So that's what's happened there. So I think maybe that you can devise actually a study which would put all these experience things, why people use more DLTs into it, and then show that, you know, why they use it. But I think science has to have a very clear question with a very clear answer, and this question here has many answers.
I don't want to argue or disagree as I actually share your views. And that's why I did not actually put my own suggestions there. Obviously, this will be an interesting debate, and that's why we are doing TOSCA. Even if we come to a decision that this is a priority for the Thoracic Committee, as represented by the members of the Thoracic Subcom, I totally agree that this will be a challenging design. I really think that even from the small randomized control trials, the immediate intraoperative messages are there. But at least in the UK, the National Institute of Health Research really wants longer term. So I think the pulmonary complications, the atelectasis, the prolonged oxygen requirement could be part of it. But not everything is randomized controlled trial. So we might actually, and we have been discussing for years, that maybe a prospective observational study, which would include all the practices. So the double lumen tubes and the bronchial blockers, and these clinical questions could be looked at as part of the prospective observational study as opposed to randomization. Equipoise is going to be a difficult thing with such big studies.
So, so we have seen different methods of airway management in our session. We have seen that we must differentiate between needs for providing only lung collapse, which is usually the case, and then sometimes we have to have lung isolation to isolate the ventilated lung from soilage and pus, or provide ventilation as such. And for lung collapse, both DLT with or without incorporated video cameras and bronchial blockers are equally good. Good choices. Local expertise and price might be guides to use one of the two methods. For lung isolation, a DLT is usually the best method, as it provides easy access for suction and CPAP to a non-ventilated lung. Newer DLTs or single lumen tubes with video incorporated embedded cameras allow surveillance of the carina and early detection of tube displacement, especially in scenarios where access to the patient is difficult. But however, it does not preclude the need for fiber optic bronchoscopes. That must be said, because sometimes people say that then you don't need a bronchoscope. Of course, you need a bronchoscope in these cases, and it might be seldom that you don't need a bronchoscope in this setting. In the scenario of anticipated or unanticipated difficult airway, DLT is usually difficult, even and sometimes impossible. Therefore, single lumen tube and use of bronchial blocker is the method of choice, and enforcing DLT intubation only if unavoidable. And a difficult airway always needs teamwork, and that should be stressed. Lung transplantation is a special case of difficult airway management. A left side DLT seems to be the best choice in most cases. And I'd like to thank everyone who has attended the webinar. We hope you enjoyed it, and I ask you to give us feedback.
I think we are good for now. Thanks everyone. It was a real pleasure to chat with you this afternoon. Just before I close really this session, I would like to introduce for a few words Fabio Garacino, Professor Garacino from Italy, who is the president of the EACTA, who would like to say maybe one word, maybe some words. Please, Fabio.
I think that this afternoon we really had a very, very excellent webinar. As you all know, this is the second webinar EACTA has organized. I think that the today webinar was really very good. The topic was very interesting, and all the lectures were very clear and I would say, exhaustive. Everything was explained in details, the pictures were fantastic, the videos were very good in quality. So I really would like to thank the chair, the moderators, the speakers, so all the faculty, and also the organizers. May I send a special thank to Mohammed El Taan, who is the chair of the educational committee, who did really a great job in arranging all this and trying to keep everything in line. And a special thank to the social media task force and the entire educational committee for their job. I would like to remind all the attending colleagues that the webinar is accredited for the UEMS, and so they will receive CME credits. And a special thank from me personally and from the entire board of directors goes to Ambu, who provided the EACTA with an unrestricted educational grant, and we are really very grateful to Ambu for this. So again, I think we had a very, very nice educational activity this afternoon. I thank all the faculty and all the people who were involved. A special thank goes to the thoracic subcommittee for their support. And please keep in mind that we are going to have an EACTA webinar in October, November. This will be from the intensive care subcommittee, and I'm sure this will be another excellent educational event EACTA is going to run very soon. So thanks everybody for joining and for staying connected till now. Thank you and bye-bye.